Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Viatris, Inc.
Hi, I'm Dr. Milan Han, Professor of Medicine and Chief of the Division of Pulmonary and Critical Care at the University of Michigan in Ann Arbor. And welcome to this program titled COPD Device Decisions That Matter. Who really benefits from nebulized therapy? And joining me today is Dr. Fernando Martinez, who's Professor of Medicine at the University of Massachusetts Chan Medical School in Worcester. Welcome, Fernando.
Hello, Milan. How are you?
Good to have you with me today. So, before we start, I want you to think about a 70-year-old woman with moderate COPD and osteoarthritis. She comes in with worsening breathlessness, and despite multiple medication changes and confirming adherence to her handheld inhalers, her symptoms really just aren't improving. So, when a patient like this is struggling, what is your process for determining if it's a medication problem or if they might truly benefit from, for instance, switching to a different device or even a nebulizer? So, aerosol therapy is a mainstay of COPD treatment. This traditionally has included dry powdered inhalers, pressurized metered dose inhalers, which you're probably both of which you're probably very familiar with, as well as a few soft mist inhaler and then nebulizers that are also on the market. Every type varies a little bit by design and manufacturer, how it's handled, and what exact inhalation technique you use with it. The differences between these devices include things like size, portability, the number of steps required to prepare it, the force needed to load it, as well as the type of inspiratory maneuver required to actually actuate the device. And then, of course, there's also things like how long it takes to use the medication, and then any device cleaning and maintenance that may also be required. So, these are kind of all the things we have to think about when we're talking to patients about medication and device choices. So, we know that these aerosol therapies are all efficacious, but the efficacy of inhaled treatment is largely dependent on the way they are used. That is just as important as the medication itself. And unfortunately, errors in inhalation technique are fairly common, unfortunately. And some studies have shown that the majority of patients in certain patient populations made errors with inhalation techniques. There are actually two studies that looked at sort of meter dose inhaler versus dry powdered inhalers and the types of errors, unfortunately, that patients often do make. So, Fernando, in your practice, knowing these errors are common, um, can you tell us, in your opinion, why proper technique matters so much and what are some of the consequences of the improper technique that you see in your clinic?
Yeah, Milan. So as the situation for availability of pharmacotherapeutics via inhalational routes has changed, that's a good thing because we have more options, and so for patients, that's great. There's the other side of that, unfortunately, which is that, as you mentioned, each of these broad categories of inhalational devices have their unique challenges. And this has been for several decades now a source of interest and of angst because there have been numerous studies that have tried to look at what are the implications of some of these device errors that you highlighted, and sort of broadly speaking, you can put the consequences into multiple buckets, and those buckets include, as your patient scenario at the very beginning, patients who have poor symptom control. So you've got them what you think is the right medication, is not helping doc, is not helping. So one potential outcome of that has been suboptimal symptomatic control. there have been a series of studies that have suggested that poor inhalation technique may be associated with not only symptom control limitations, but also increased exacerbations, overuse of inhaled or even oral corticosteroids, which is related to higher healthcare utilization. When you put all that together, you can make a cogent argument that one of the key consequences of technique errors is the totality of all that is just not the optimal health status and quality of life. So you may be expecting to see a certain level of benefit, and you're not seeing it. And so I turn the question back over to you, Melan, as I think, given that information, what do you do in your clinic to try to get a sense of whether the patient is doing inhalational therapy appropriately, and how do you address that?
Well, I'll be honest, in an ideal world, and I'll admit, this was easier to do before the pandemic. I would have someone in the clinic actually go over technique with the patient when it was prescribed, ideally when they would come back. We had and still have something called an in-check dial that we can look to see um, uh, how well the patient is, what kind of force they're generating and flows they're generating. Um, and then match that and make sure it matches up with the device that they've been prescribed. But I'll tell you, in reality, some of the challenges I think we're increasingly facing are that medications are getting switched not at visits, but because insurance is switching them at random times. Generic gets suddenly swapped out for something that you trained the patient on and it's different. And then, the other challenge is a lot of my visits for a lot of my CPD patients are done virtually now. And I can't do that same level of training. So, this is where sometimes, for instance, you've got to rely on videos. Sometimes you're relying on a pharmacist if available. But a lot of my patients are also getting their inhalers from mail order pharmacies, so that doesn't help so much either. So it is, I would say it's still very important. I just think it's gotten, to be honest, in the last few years, even more challenging in real practice to actually get this done.
Yeah, I mean, I think you hit this right on the head, this nail, Milan, because I think that, and the pandemic really did change this because everybody's staffing is changed, and
We're
whereas we
thinner than we've
previously,
ever
uh,
been.
oh yeah, I mean,
Yeah.
we previously had very functional approaches, and that's all been thinned out, as you said. And I think that some of the components that really accelerated during the pandemic, which was the increased reliance on telehealth, has made this a lot more challenging because you no longer have the opportunity of saying, bring in every one of your inhalers and, we
Yep.
can have
Yep.
someone go over
Yep.
it. Nope. It's all done virtual now. So people are trying to show you on the screen what they're doing. And something else that you mentioned that's happened to me twice this morning was the issue of the pharmacies that are mailing things to patients, and all of a sudden there's a different device, and you're getting the call regarding, this is not the same thing that you guys are telling me about. Yep, you're right. And so I think all of that has really increased some of the complexity. And I think we've become much more dependent now on YouTube videos, Milan, and referring patients to the YouTube video to be able to ensure that they are using devices correctly. I think that pharmacists are particularly good at this, but having patients going and interacting with their pharmacist is a lot less frequent now than it was in the past. It really is much more of a challenge.
So, in light of that, I think it'd be good to review sort of what the landscape of aerosol therapy options are and what differentiates each device. So, I wanted to start with the handheld devices. So, the real question is, what do handheld inhalers offer? But also, where might they fall short for specific patients?
Well, so you know what? In this respect, this is actually one of the things I use for the fellows, Milan. There was a publication that was published just a few years ago, and I think it was in expert review in pharmacology or something of that sort. And it really presented a summary of these devices that is easy to understand. And I've actually tried to modify this for patients as well, which is to say that you can really kind of look at these inhaled device approaches into two broad buckets. One are devices which are just a press and breathe inhalers. and that's where the aerosol is delivered by the manual activation, and that requires some hand-lung coordination by the patient. Even so, the MDIs are the classic one of those components. And then there are the breath actuated inhalers, and there are a group of those components where it's the user's inspiratory flow that sort of triggers the delivery. And you can put most of the inhalational devices that are handheld into those buckets, and it allows you to look at their advantages and disadvantages. So both sets, whether it's the breast actuator or the press and breathe, have the advantage, which is why we've used them so often, that they're portable, they're easy to use, they take a short period of time to use. They're sort of preloaded with medication. They have a lot of doses. Many of them have dose counters. You can track how much you've used. There's limited amounts, no zero, but there's a limited amount of setup. They're low maintenance, and they're relatively easy to use with most of the medications, not all, most of the medications that you and I would consider to be vital for our COPD patients, including combinations, are available in these devices. So that is it's a good thing. That is the advantage of those devices. Unfortunately, each of those has their own types of errors and unique idiosyncrasies. And so that same paper actually provided this lovely meta-analysis of all of these papers that had been published over a couple of decades, and looking at the devices and sort of the broad categories. And so, for example, in uh, the press and breathe, mostly these being MDIs, there were a series of um, errors that were seen frequently, and that included one of my very first papers, Milan, that I published decades ago, was actually a patient who came in who had suboptimal control, that had consistently removed to had forgotten to take the cap off the device. So he brought everything in. I'm like, oh my god, this is pretty straightforward. I don't see you don't see that nearly that often anymore. But what you see are things like not shaking the inhaler, not exhaling fully before you take the next inhalation, uh, forcefully exhaling into the device, and then one of the more common things is just it's not taking not holding your breath long enough afterwards. And so the NDIs, which do require some hand-eye coordination, do have their unique components. And then you think, all right, what about maybe it's easier to use these breath actuated devices? DPIs are the ones that are most common, and that's some of the most common devices that we see in the COPD space. And that had their own unique components, which include not having a full exhalation before you inhale, not having a rapid inhalation, no breath holding. So, and then there's this whole issue regarding the inspiratory flow rates and the ability to trigger some of these devices. So, the good component of this section is that we got a lot of devices, and most of the medications that we like to use are available in one of those devices. However, each one of those devices has their idiosyncrasies with regards to what you need to do for education. And that highlights all of the components that you and I just mentioned. So, with that in mind, I'm going to turn it back over to you, Melon, and say, so given that we have these different types of devices, how do you conceptualize the most common reasons for device mishaps in your educational process for your patients?
I mean, I think one of the biggest challenges is that the meter dose inhalers usually are it's more of a slow coordinated event, whereas the dry powder inhalers needs to be a deep, quick inhalation. But then we're switching patients depending on insurance back and forth. And I'm not sure that usually in their mind, there's like one way I take an inhaler. And so, to be honest, sometimes our devices don't help either. I'll digress for just a second because as you know, my son has, we'll call it reactive airways disease. I've been hesitant to call it asthma, but he uses an inhaler, and he uses because he's a child, right? So a lot of times children are using the meter dose inhalers, and he has a spacer, which is correct. But he always thinks it's right when he hears the whistle. which is not what we're going for usually when we're trying. But so there's so many challenges. But I do think honestly that one of the biggest ones is just that the techniques are so different, and that we're often just going back and forth based on kind of this insurance bingo. And I don't think most of our patients realize that whatever it is they got taught for the first one, and if they get switched, doesn't necessarily apply.
Yeah, well, and that's not only your son, a kid. He's a smart kid, so if he's having that problem, this is a challenge. But that also as a side story, Milan, I remember when my father-in-law, I put him on one of these SMIs, one of these soft mists. I
Yeah.
broke two of them trying to show him how to
Trying to show
use.
them how to load.
Oh my god, that's all I had to end up paying for the third one myself because this insurance company wouldn't pay for another device. And so I think there was another paper that was another one of these recent papers that actually looked at something that just highlights what you just said, and that it was looking at people who were younger than 65, or some of us that are older than 65, highlighting that if you're over 65, you're more likely to make errors. And if you had mixtures of devices, an PMDI, a DPI, you were much more likely to see incremental device errors when you had multiple devices that were being used. And so again, as we've stated from the very beginning, having all these medications in a broad range of devices is a good thing because you have more options. On the other hand, it creates a significant number of additional challenges that unfortunately we have to deal with. So that brings up another question, Milan, which you and I have talked about before, and that is, given all the good and the bad of the hand devices, where do you conceptualize having nebulization?
I mean, I think it is very, very nice to have the option. I think we as physicians often think, oh, but there's the extra equipment and the time. But I will say, I have many patients who, to be honest, often get introduced to a nebulizer in the emergency room. That is how a lot of times patients kind of even know these exist. As physicians, they are not necessarily the first thing that we think about. But I have many, many patients where it probably is the optimal way for them to get their medications, and they love them and they don't mind the time. It's not correct for every patient, but I do have a lot of patients where it's really helpful. There are a lot of medications that are, in fact, almost every class of medication now is available in nebulized format, right? So that's short acting and long acting beta agonists, muscarinic antagonists, as well as one of the newer medications that we have now approved for COPD, and a PD3, PD4 inhibitor. There are multiple different kinds of nebulizers out there that are available: jet, ultrasonic, vibrating mesh. I think most of the ones that are currently on the market can you know are not necessarily nebulizer specific. There have been some on the market in the past that were nebulizer specific, but I think one of the advantages is it doesn't require the dexterity. It's much less prone to errors. You don't have to have the coordination issues. So um, on the downside, it is a little less portable. You do have to clean it, and the administration time is longer. But for some patients, and in my son's case, that's sometimes in children, but also in older adults, where there might be coordination issues, arthritis issues, dexterity issues, or even some patients, just for whatever reason, just like it better. They just feel that they get better medication delivery. I have one patient in particular that we switched one of her medications over, and she liked it so well that she just asked me to switch all of her medications over, and I actually found that she had better symptom control, and just overall felt better when she was on nebulized medication. So it's obviously it's an individualized decision, but I definitely have some patients that really just love nebulizers. So, I'm curious, Fernando, how do you decide in your practice when to use nebulized medication? Are there, what are the kind of pros and cons? What are the things that you're thinking about?
Yeah, well, a lot of the things that you mentioned were things that resonate with me a lot. I think I've told you, I look at a lot of things through the point of view of my father-in-law and his pet COPD, and he was a smart guy, and how I dealt with these things. And I think that as you mentioned, uh, there are patients who just like providing nebulization. They understand the limitations, takes longer, they're not as portable, but they, particularly once they're hospitalized, they think they're getting more of the medication because that's what they gave me in the hospital. Okay, and nevertheless, I think that there are some challenges that, and you and I have had to deal with these in individual patients. In that, in some settings, nebulization is viewed as being only for people that have more severe disease because they got it in the hospital, so it's for severe disease. And just as there's complexity with the handheld devices, there is some complexity with regards to nebulization because there are different devices that have pluses and minuses. My own bias, it's to some extent they're actually easier to use than the handheld devices, and there are some practical barriers. Which is something that you mentioned, which is pretty much all of the medicines that we use in whether it's a breath actuated or press and breathe are available in nebulization. The doses are a little bit different. So you got to figure out how to convert these things over and how to even mix them. So that can be a bit more of a challenge. But I think that part of the question that comes up is a question of practicalities with regards to cost and insurance and how to get some of these things covered. What's been your sense with regards to how to conceptualize the process of potentially starting or switching or adding nebulized therapy to what the patient's therapeutic armamentarium is with regards to insurance coverage issues and access? What's your sense of that?
Yeah, I mean, one of the things that sometimes regular pharmacies forget are that nebulized medications are covered under Medicare Part B and not Medicare Part D. So, what we have ultimately switched to at the University of Michigan is switching to try to get most of these nebulized medications through pharmacies that are very familiar with the process. They know it needs to be processed through Part B, then Part D. They'll send us a note if the patient doesn't have nebulized medication. They're very good about training the patients and making sure that they've got everything they need to be successful. So for us, I know that may not be sort of readily available maybe to everyone, but it's worth investigating. Um, uh, in your local area, this is something a journey I kind of went on recently here at the University of Michigan, and it ended up just there are more and more nebulized medications that seem to keep coming available, and we want our patients to have access to these. So I think one of the key things is trying to work with pharmacies that just understand the process and are willing to kind of push through those barriers, work with you, work with the patient to make sure that the patients get access. But having once we've kind of worked through some of those things, at least at my University of Michigan, it's been very successful.
Milan, you've been part of the Gold Science Committee now for a while, and I know we've debated this in Gold because U.S. is more nebulized friendly than the Europeans are. What's your sense in terms of what Gold has recommended with regards to delivery devices in general and nebulization in particular?
Yeah, well, I think the Gold Report really emphasizes an individualized approach, realizing there's going to be differences in what's available in a given country and what you can get for an individual patient based on insurance. But trying to, in an ideal world, match the patient to both the device as well as the molecule to their needs, what would treat them best, and their lifestyle. Realizing certain patients are going to have certain barriers and continue to struggle with certain aspects. So that's why it's really ultimately kind of an individualized decision. I don't know, Fernando, in your practice, are there certain things that you see are really common that clue you in, like, this is probably a patient who's either not using it right or a standard inhaler isn't going to, and I probably should think more about a nebulized medication.
Yeah, well, I think this, as you know, Milan, this is one of the things we've talked about in Gold for a while, and I'm glad that Gold recognized the fact that it's not just the type of medication, that it is the approach to delivery of the medication, and that has to be personalized. As you and I both know, that the U.S. Overall marketplace is a little bit different than the ex-U.S. because there are some additional challenges that we deal with our fragmented system, the insurance components, as you mentioned. A lot of those are to some extent unique to the U.S. right now. But I do think that even the patient you described at the very beginning during your reflection highlights some of the things that I think we've all sort of seen that are broad brushes, not particularly dictums, but there are things that are in general. The older you are, the more likely you are to see some challenges with using inhaled devices. We need to consider the potential of nebulization, and that that their cognitive decline and some of the dexterity issues. Trust me, as you get older, these things are common things. I think that if you have multiple devices with different medications, you are more likely to see some of these errors. And then this paper that I just mentioned to you that was recently published confirms that. I think that there is the potential influence of some of the comorbid conditions, whether it's neurological disease or arthritis, like your patient from the very beginning. They may not have the dexterity to be able to use some of the particular handheld devices. So I think some of those are relatively straightforward components that I think all of us could see logically. All right, those things make sense for why you could potentially see problems with using a handheld device, and there's potential that a nebulizer would be helpful in that respect. I think one of the other components, particularly in the area that I practice now, Milan, versus when I was at the U of M, there's a lot more language variability in this neck of the woods. And so some of the educational components, if you add to that, Milan, multiple different languages, and you're doing something by telehealth with an interpreter, now you're really talking about some interesting, challenging areas that come up in sort of practical care. And so I think all of those components are in general appropriate. But you mentioned something from the very beginning, and one of the patients that you noted, and that is, I think clinicians need to realize that if they're seeing a patient who they think they're treating with sort of standard of care, what should be done, and the patient is just not doing
Doing
well,
well, yeah.
they're not feeling well, or they're having recurrent events, then one of the things that I think you and I have always tried to get across to people is just remember, make sure the patient is getting what you think they're getting, and have that come up in your mind, not just some of these really other obvious components. I think that's one of the key components.
Yeah, the things that I try to think about are one, we talked about dexterity issues. So, that's certainly one of it, arthritis, tremors, which can be more common in some of our older patients. But increasingly in some of my older patients, cognitive conditions, whether it's, dementia, Parkinson's, some of these other, it's kind of, I have some of my patients I've had for so long, and it can be a little bit heartbreaking to see some of them have, that were, very cognitively engaged 5 years ago, and now are starting to come in with their spouses or caregivers, and are starting to suffer some. I know you've been through this, Fernando, with your extended family. So, but that's another time where you might want to think, okay, there's been a life change here. Something has happened. Is the regimen that I have had these patients on still the right regimen? For I don't know. So those are some of the triggers for me. How about you?
Yeah, no, same idea. I mean, I think that it is sad to see, Milan, as you and I have gotten doing this for a long time, is to see your patients age with you. And as you get older, you start really appreciating what your patients are saying in some of these challenges. I think that it is hard, particularly when you have a busy day, you've got, 10, 12 patients that you've got to see quickly. I mean, it's hard to keep this in mind, but I think it is important for you to realize that, particularly as patients age or as they have more prominent comorbid conditions. And by that, I mean the comorbid conditions are having more of an impact on these patients. It is when you need to start thinking, it's not just the medication that I'm prescribing, but it's how that patient is going to be using this. And I would say, Milan, it's certainly a laudable goal to say at every visit, we
Yeah,
screen patients and consider every one of these
yeah, but
components in every visit.
it's not going to happen every visit. I think we all know that.
Unfortunately, it's just not practical. And so, I mean, I think that as I'm thinking about sort of the key things that we would leave folks with, Milan, it would be what would be the key clues that potentially something is amiss that needs to have you rethink the way you're delivering.
Yeah,
You mentioned some of the key components: an older patient with comorbid
yeah,
conditions, life events. But I think people who are not doing well
yeah. More
or
just
requesting multiple refills, that
using
kind of
too much
tells you
albuterol, or
something's up.
having frequent exacerbations, or telling you that they're very symptomatic despite lung function being the same, or just like, what is there something that just doesn't seem to, um, doesn't seem to, make sense. So, as we kind of get to the end of this discussion, let's hear from a patient who achieved better control of their COPD symptoms after switching devices. And while we watch this, I want everyone to think about, based on what we've discussed so far, what's one thing you might change in your practice regarding aerosol therapy device assessment?
My name is Yvonne Jones, and I've had COPD for about maybe 20 years. So, about 20 years, since 2007, I was diagnosed. Well, COPD, before nebulizing or anything, COPD had me where I couldn't do too much of anything. I love to dance, and I couldn't dance before. And I like to do some sports activities. I like to run. I like to play baseball sometimes, and that's that was tough for me. Being on a nebulizer has changed my life. Like I said before, I can do so many things now, and before without the nebulizer, and I wasn't nebulizing and stuff. It was a struggle. The doctor recommended that I nebulize, and so that's what I do now. I nebulize. It's part of my everyday routine. I do not leave the house without nebulizing because I know that's going to get me through the day. If I travel, I take it with me. That goes with me, and I do it just like my regular routine. If I'm on vacation, which now I can do, I just pack that nebulizer up and take it with me. And the same thing in the evening, just before bed, I nebulize. I get a good night's sleep, wake up refreshed in the morning, and start my day again. With my flare ups, the flare ups I was having was beginning to be more frequent, and I was going on steroids to calm that down. And the steroids was beginning to complicate other things in my life, such as blood pressure, diabetes. It was really, the steroids was not that great for me, but it did help with the COPD. But instead of taking steroids now with the nebulizer, I don't go on steroids hardly ever, maybe once or twice a year. And that depends on how bad the weather gets. I was happy when I started nebulizing and realizing, hey, this is keeping me off the steroids. And so now it's a part of my life, my everyday routine. Now, I can dance, I can run, I exercise 3 times a week. I walk a mile each time I go, and I don't have any problems. I don't have to use a rescue inhaler or none of that to do all those things that I do now. So life for me has changed.
So, to wrap up, having so many different device options is good. We can tailor treatment to patient needs, but it also makes choosing the best device more complicated. So it's, one of the things I hope you take away from today is just remembering to consider that there are a range of patient factors that are important to consider when we decide on a device and molecule option for a patient, because ultimately we just want a successful outcome for patients, but that could be comorbidities, lifestyle, patient preference or experience, or it could be, as Fernanda says, you just are witnessing that the patient isn't responding the way that you think that they should to the medication that you're giving. So we want to thank you so much for just spending a few minutes with us today. And Fernando, thanks for joining me for this great discussion.
Always a pleasure, Milan.
And thank all of you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.